Okay, so we are going to start on today's session. If my network lags, someone can just give me a text via WhatsApp or the class rep. I hope the class rep is around, can be able to tell me that my presentation maybe is not visible, or maybe you can be able to hear me from your end. Yes, so as you can see on your screens today, we'll be covering cardiovascular pathology. And that's me. I've done BSc Human Anatomy, and right now I'm studying medicine and surgery, level 5. My name is Kimani, as you can see there. So what are we going to review today? What you're going to review today, you're going to review cardiac anatomy and physiology. That is the normal functioning of the heart, the various parts of the heart and how it works. We're also going to review congenital and valvular diseases. Congenital are birth malformations. And then you'll have valvular diseases. Valvular diseases are diseases that affect the valves of the heart. Maybe you heard about tricuspid, bicuspid valves. So those are not the diseases that affect those valves. We are going to cover the major cardiovascular infections. So even the heart, same way the body, you can have infections. Also, the body has infections in it. The heart can have infections, can be infected. And then you're going to describe what are cardiomyopathies, the three types of cardiomyopathies, and then you're going to check on the overview of arterial and venous disorders. I'm going to take a very short time. Within the next 1 hour, I'll be done. Yes, so I'm begging for your attention, so that you can be able to understand, especially now the first part. I want you to understand the first aspect of what we'll be talking about, so that you can be able to understand the pathologies that we'll be covering. And so, as an introduction to the cardiovascular system, as you can see there, so this cardiovascular system transports blood with nutrients, gases, hormones, and waste products in the body. So that's a function of blood, is that it transports nutrients, gases, hormones. So nutrients is not the food that we eat. Gases, oxygen, carbon dioxide. Hormones, you've heard about estrogen, testosterone, and such. And waste products. So after you take in nutrients, the body will give out the waste products that now will be released to the body using now the respiratory system, or the alimentary canal. Yes. And that's what now is cardiovascular system. You can see at the center here we have the heart, we have the two lungs, of which now in them we'll have the pulmonary system. You can see pulmonary artery and pulmonary vein. And then you can appreciate now on the body, we'll be having the arteries, the larger one being the aorta, and then the vein with the superior and inferior vena cavas are being here. So that's majorly it. The components, you can see them there. So the heart, the blood vessels of which you have arteries, veins, capillaries, and the other component is blood. So in an exam setting now, I can tell you to list for me the components of the heart, the components of the cardiovascular system. Well, I expect to mention about heart, blood vessels, give the examples of blood vessels, and the blood, and maybe in the exam setting also I can ask you what are the various components of blood. Then the other question that I can ask you is that what is the function of the heart in that regard? Yeah. So the heart blood to vessels, tissues, as you said earlier. So this heart acts like a pump, pumps blood to the vessels, through the vessels to the tissues, as you can see here. So this is a heart using these arteries to pump blood to these tissues, to the lungs and to the body in that regard. And then ensures delivery of oxygen and nutrients, and then moves waste products. And failure of this cardiovascular system will lead to, like, the body lacks blood, lacks nutrients and oxygen. So due to that, you'll have organ damage. Remember, the tissues have cells that continuously require oxygen and nutrients for them to be alive. If they don't, if they're deprived of that, they will die. Yeah, so just to mention that this now the anatomy of the heart. I hope you can appreciate the anatomy of the heart here. And for this anatomy of the heart, I would like us to appreciate on the outside aspect of this heart is that it has four chambers, which you see them here on the inside aspect of the heart. On the outside aspect of the heart, be able to appreciate that we have this right auricle or the right atrium, is the right ventricle, this left ventricle, the purpose of the heart is usually the left ventricle. And then these are the blood vessels. The blood vessels will comprise of now the pulmonary trunk and the aorta, and then you can be able to appreciate superior vena cava, the inferior vena cava here. Just also to remind you of the coronary system. When we talk about the coronary system, that's the blood vessels that supply the heart. Consider right coronary artery and the left coronary artery, and the vein of the heart is this coronary sinus, and you can see most of them will appreciate it at the back. So that's the outside of the heart. In the inside of the heart, you'll be expected to know the chambers now. This is the right atrium, right ventricle, left atrium, left ventricle. So ideally in anatomy, we don't have something like left auricle representing an auricle by an atrium by itself. Yes. So this an auricle is an appendage of the atrium, an extension of atrium. Where you can appreciate now the inlet blood filament coming filament of the right atrium. The right atrium blood goes through the tricuspid valves. So we can see the tricuspid valves here. The tricuspid valves to the right ventricle, from the right ventricle now to the lungs. Blood will go to the lungs using this pulmonary trunk. The pulmonary trunk divides into two pulmonary arteries, the left one and the right one. The blood goes to the heart, to the lungs, sorry. From the lungs into the heart again using the left. Using the pulmonary veins, especially for in number, you can see 1, 2, 3, 4 pulmonary veins. If the left atrium, from the left atrium into the left ventricle to this mitral valve, and left mitral valve now to the aorta to the body. And you can see blood in the right side has a lot of carbon dioxide. That's the reason why it's blue, and the other side is red, because blood is well oxygen coming to the lungs. So it's really be important in terms of us understanding the cardiovascular pathologies. In terms of histology of the heart, histology means study of tissue. So we know ideally the heart has walls. So it has three walls. One of them is endocardium. So endocardium is this lining that you can see here. So it's just very small. It's actually innermost layer. So these are hearts. So once you magnify this vascular portion here, it will give you three layers. The innermost layer is endocardium. Then this is actually the deepest layer, and its function is just to reduce the friction. You can remember this. Culture of this heart is to pump blood. Then you have the myocardium. Myocardium is actually the largest part of the heart. It's a bit layer. It's the right aspect. It has muscles. So you've heard about cardiac muscles in your anatomy. So the functions of these cardiac muscles is now, remember, muscles contract and relax. So once they contract and relax, they enable pumping of blood from the heart. And then now we have the last here, which is the epicardium. Epicardium noise, the whole of this. So this epicardium will be divided into two. It has outer protective layer, which is called the fibrous pericardium. And then it will have the visceral pericardium. So you appreciate now this is the pericardium or the epicardium. So it's the outer protective layer with the visceral and parietal pericardium, and those we can appreciate the fibrous pericardium there. Okay, so functions of the heart. One, as a mechanical pump, the reason why it's pumping blood. So it's pumping blood in that regard. The other one is generates blood as cardiac output to the tissues. That's again related to the mechanical pump. So what is it pumping? It's pumping blood. Why? Because this blood is carrying oxygen, nutrients, and those things. So it require electrical activity. So electrical activity means the heart has it has to be activated by something. And as you've heard, the heart can be able to like activate itself. So that means it has it has a conductive system in itself. It has a conductive system in itself. So the cardiac arrest marks the death of a person ideally. Yeah. So we will go through this conductive system in a few minutes. And the first thing that I like to appreciate is the cardiac cycle, electrical activity. So cardiac cycle is now the phases that blood takes once it gets into the heart and out of the heart. So remember, blood is coming into the heart from the body, then from the heart to the lungs, from the lungs back to the heart, and then from the heart to the body. So it has phases, and these phases, as you can see here, some of them will be called diastole. One of them it has two phases, diastole and systole. So diastole is the ventricular field. So we've talked about the ventricles of the heart. So when blood is getting into the ventricles, that's diastole. When now blood is being pumped from the ventricles out of the ventricles and ejected out of the ventricles, that is systole. So diastole is the ventricular filling, systole is a ventricular contraction and ejection of blood from the heart. So I hope you can be able to. So those are two important phases that I'd like you to know about them. Definitely we have valve dynamics. So valve dynamics means the valve will open and close. So they will open, given that it actually want to blood to get into the ventricles. So the valves will open in diastole because you want ventricles to get blood. So once the ventricles are full, you want to contract and you want to prevent the blood in the ventricles from going back to the atrium. So you have to close the tricuspid and mitral valve. That's the reason why if it is atrioventricular valves will open in diastole and close in systole, and then semilunar valves. So semilunar valves are now the pulmonary valves and the valves that will open in systole because you want blood to go to the lungs and to the body. So regarding the electrical conduction, I want us to look at the image that I've put there. So the heart can be able to contract and relax without nervous stimulation. And that's a question that I can ask you in an exam setting. I can tell you to list the electrical conduction system of the heart. And then you're supposed to know like the initial one is a sinusoidal node. From the sinusoidal node, the atrioventricular node. From the atrioventricular node, you have a lot of his. Then you have the right bundle and the left bundle. And then from there you have the Purkinje fibers or the Purkinje tissues. So I will ask you that question. Then another question that I can tell you to tell me is how many beats per minute does the heart beat? That I'm expecting you to put in your answer 60, 100 beats per minute. Yes, so cardiac output. When we talk about cardiac output and regulation of this cardiac output. So when we talk about cardiac output, I will be expecting you to tell me that cardiac is the heart. Output is something that is being taken out. So what is being taken out is blood. So I'm expecting you to tell me cardiac output, the volume of blood pumped by one ventricle per minute. I'll be expecting you to give that as your answer because you know what is a cardiac. Cardiac is a heart. Output is common sense, something that is going out. So what is going out of the heart? It's a volume of blood being pumped out by one ventricle of the heart per minute. Remember, we talked about systole and diastole. So, what is the formula of getting a cardiac output of a person? So, cardiac output is equals to heart rate. Heart rate is beats per minute. So of course, you talked about the beats per minute of a person should be 60 to 100 beats per minute. And then stroke volume, the word itself is the volume that is ejected out of the heart per beat. So we've talked about this volume of blood being, okay, this beats per minute being 60 to 100. That's the heart rate. Then the stroke volume. So stroke means the blood, the blood that is being pumped out during systole. So volume ejected per beat. Per beat, that means between 1 minute, and then you multiply. So that cardiac would be that heart rate times stroke volume. So what will be now determining the stroke volume that we're talking about? So stroke volume: one, preload; two, afterload; three, contractility. Preload is the amount of blood that is getting into the heart, maybe through the superior vena cava, inferior vena cava, and the pulmonary veins. Remember, all those have veins, so blood coming in into the heart. That's preload. Two is afterload. Afterload means now you're pumping this blood into aorta and pulmonary arteries. So there is that amount of force that will be used. So that's vascular resistance into those arteries, and then contractility. Are the heart muscles be able to contract well and relax well? So that is what will determine our stroke volume. So once you maybe you increase the stroke volume, heart rate will remain the constant and cardiac output will increase. If you decrease stroke volume, you will also be decreasing cardiac output. So these are wouldn't really measure on this regulation of heart functions. So the heart can be either increased or decreased by sympathetic function. So once you see a snake, your heart will start beating faster to generate more energy. So that's sympathetic. So you can be able to run more. You can be able to provide more oxygen to your tissues. So that's sympathetic. The other one is parasympathetic. Once you are relaxed, you've eaten, and you know you are relaxed, your heart will be beating fast. So you have decreased heart rate because you want to rest and digest. And the other one is Frank Starling mechanism. Now, things regarding, okay, just know there is Frank Starling mechanism, which is determined by vascular resistance, leading to other conditions such as edema. So just know about Frank Starling mechanism. Yes, but the most important one is number one and number two. Frank Starling mechanism will come into that later. Or I hope you are taught about it when when you're doing cardiac physiology. So also this is physiology, so I won't really major on it. So regulation of circulation is controlled by nervous and hormonal mechanism. Nervous mechanism is the one that we talked about, sympathetic and parasympathetic, where now the baroreceptors will be present in the carotid sinus will regulate the pressure. And these are not in our system, then it goes there. So this is you can take a screenshot of it and see how now these are hearts, these are hypothalamus, and how they control one another. Okay, so let's start with congenital anomalies of the heart. And these congenital malformations of the heart, by definition, and this definition is important for us, that these congenital malformations are structural abnormalities of the heart that are present at birth. So they are present at birth, and they can either be two. Will come into the so, but overview of it is that they come across due to genetics and also due to environmental. So genetics, maybe you have genetic mutation. You've heard about genes. So genetics will due to chromosomal anomalies. Then it's environmental causes. Environmental causes can be things like maternal infections. So you've heard about syphilis, toxoplasma. You've heard about drugs, so taking of alcohol, and themselves, hard drugs, diabetes, especially diabetes mellitus and hypertension. They really affect this. They can affect a child to have little heart malformations. So guys, have with us classification of this malformations. You can have one acyanotic or cyanotic. That is a classification. So when talking about acyanotic, that means blood can be able to move in terms of circulation. Blood can be able to move from the left to the right without going through the lungs. Remember, we talked about you have that thing. That's a cycle. Though I'll show you the image area of cyanotic. Just know that classification is acyanotic and cyanotic. So this is it. The normal heart anatomy. I want us to look at this side image, right? So the normal anatomy is that blood from gets into the heart. You see the two superior vena cava and inferior vena cava into the right atrium. Then the right ventricle, from the right ventricle to the pulmonary artery to the lungs. From the lungs back into the left atrium, you can see in red. From the left atrium to the left ventricle, from the left ventricle to the aorta, and then into the body. So when you're having these issues, when you're having these anomalies, one acyanotic means blood is coming out. So it's coming. Let me start with this cyanotic. Cyanotic one. Let's want to understand. Let me start with it. Cyanotic, blood is coming to the left, the right atrium. I'll show where with it there, left atrium. Then goes to the right side, so right atrium, right ventricle. Then instead of going from the right ventricle to the pulmonary trunk, you have the blood going into the left side. For example, here you can see the ventricular septal defect. Ideally, it should be complete, but because of that, blood is moving from the right side to the left side without going to the heart. So that's the reason it's right to the left shunt. Right. Then there is other one is cyanotic. So blood is coming into the left atrium, from the left atrium to the left ventricle. Then from the left ventricle, the blood decided to come back the right side. So it's now the left right shunt. So a cyanotic is left to right, and then cyanotic is right to left. So I hope you can be able to get that difference. And now this is a difference now. So cyanotic, because ideally the blood is is not going to the lungs, you'll get blood if you will not be well oxygenated. The person will atakuwa na turn bluish in color because of that thing, low oxygen levels. But now, in cyanotic, blood has already been into the lung, so it is coming back now, being well oxygenated. So ideally, this person will be turn bluish because blood is well oxygenated, and the issue is on the left side and not on the right side. And the clinical feature now will be there. Here, mammals are abnormal heart sounds. The other one is heart failure with the heart can, because of that straining in pumping blood, it will have cardiomegaly, an example of cardiac failure or heart failure. Then cyanosis is the bluish appearance now. So it's in the cases no oxygen levels now making the person to turn bluish. That is cyanosis. I'll give us now examples of cyanotic heart diseases. I've already explained, but now this one is to make you understand them well. So cyanotic heart diseases, we talked about them being definition. So there is right to left shunt. So for example, in this, blood is coming in. It's not the normal heart. Blood is coming in right atrium, right ventricle, into the pulmonary vessels to the heart, and then comes back to the pulmonary veins, the left atrium, left ventricle, and then the aorta. So the other way around now, if you have a shunt means the blood is coming into the right side, that is the right atrium, right ventricle, but the blood is going directly to the left side because of this anomaly here. So there is that mixing flag. I hope you understand that. So due to that, now you have a lot of deoxygenated blood, like this blood of heart, not into the heart, with the left side because of this shunt here. In the common types now. So definition of that, there is a right left shunt giving you oxygenated blood entering the systemic circulation. The types that I will ask you in an exam setting that I will expect you to give me the five T's, as you can see there. So common types, they are the five that you can see there. The five common types. So one of them is the pathology of follow. The other one is the transportation great vessels, the great arteries. The other one is tricuspid atresia. The other one is total anomalous pulmonary venous return and tricuspid arteriosa. So that is what I will ask you in an exam setting. I won't go deeper and how, like for example, this is different from this, but I'll be expecting you to give me examples of cyanotic heart diseases. So pathophysiology, I won't ask you the pathophysiology, but understand how is it a cyanotic? How is it cyanotic? Sorry. Clinical of it because of these chicks in the blood. Of course, now the person will have cyanosis. And due to cyanosis, the person will have clubbing of fingers. Like fingers looks like a club. Club ni rungu. Like vidole zinakaa rungu. Yes. Okay. Then from the complication is hypoxic spells. Hypoxic means the person is less oxygenated because the blood is deoxygenated. I hope you understand. Then the other thing that we need to understand is now we can go to cyanotic heart diseases. The cyanotic heart diseases, now it's the other way around. So these are not what we talked about. So blood comes in that way, goes to the lungs. And from the lungs comes back. Can see this arrow here. Left atrium, left ventricle, then to the aorta. So in an abnormal thing, in an abnormal, a person with a cyanotic, like blood comes in, as you can see here, blood comes in, as you can see. Like on the right side, the blood is normal, like only just covering fear and covering the right side in a talk covering the pulmonary vessels, then from the pulmonary vessels, it's to the pulmonary veins, from the pulmonary veins to the right to the left atrium. But not from the left atrium, you can see like the blood is coming in here. Like this is oxygenated blood, and there is a atrial central defect here. So blood is talking from the left side to the right side. And from there now, there is that missing blood. So yeah, normally the blood flows from the left side to the right side. That is oxygenated blood is already oxygenated, but no, it's coming back. Isinde ikizunguka. And that's now the understanding that I want to get you. I want you guys to understand the difference between a cyanotic and cyanotic. The types is that we have atrial septal defects, ventricular septal defects, patent ductal arteriosus, pulmonary stenosis, coction period. So know the difference, know examples of cyanotic and its definition, examples of a cyanotic and like its examples. For the pathophysiology, I will ask you, for the clinical feature, I would ask you, but a complication of a cyanotic, this one I will ask you, like, because of this blood is going around into the lungs, you have hypertension. You have hypertension. Yeah, so we can go to the next slide. Now telling us the valvular heart diseases. For these valvular diseases, ideally they are just disorders affecting the heart valve. So remember we talked about the tricuspid valve that I showed you earlier in your anatomy. The mitral valve that I showed you, mitral valve is also known as bicuspid valve. I showed you the aortic valve to the aorta. I showed you the pulmonary valves to the pulmonary trunk. So ideally, because they are valvular disease, you'll be expecting the disease affecting heart valves, so leading to dysfunction in terms of their structure and function. So types that will have stenosis. Stenosis means narrowing. So narrowing, so the valve narrows, so that means blood can be able to to go well. So they impaired blood flow, impaired forward flow of blood. Then also it can regurge. Regurge means it can be able to, once you pump blood, yes, blood inaingia but haiwezi jifunga vizuri. So kwa sababu haiwezi jifunga vizuri, damu inarudi. So remember you're pumping blood from there. For example, I can give you an example from the right atrium to the right ventricle, and then you have the tricuspid valve. So once you pump blood from the right atrium to the right ventricle, you'll be expecting now this valve to close. So if they close well, that's a normal heart, a normal tricuspid valve. If it doesn't close, that will be a regurgitated tricuspid valve because it has that challenge here. And now this is not just to show us the narrowing of an aortic valve. So if you know the aortic valve here, so it's narrows here, as you can see. So if narrowly affected here, then stenosis like can be able to flap well. So this shows the various valve. Tricuspid valve is here. This is the bicuspid valve or the mitral valve. This is aortic valve to the aorta, and then the other one is pulmonary valve to the pulmonary. Then the commonly affected valves is that we have the mitral valve. So mitral is the most affected one. Then aortic, the tricuspid, then the pulmonary valve. So these are very important order. I want you to know this order in the way these valves are affected. So you start with the mitral valve, which is here. Then from the mitral valve, aortic. From the aortic, you go to tricuspid. From tricuspid, you go to pulmonary valve. That's the order of how they are affected. Then the other thing maybe that you need to appreciate is that what leads to these valvular heart diseases. So valvular diseases will present, maybe you've had people talking about rheumatic fever. So rheumatic fever is, so in rheumatic fever, you'll have a disease of the heart called rheumatic heart disease. So rheumatic heart disease can lead to issues with heart valves. The other one is calcification. Calcification is by the name itself, deposition of calcium into body tissues. And then that one is infected endocarditis. So once again, infected endocarditis, by the word itself, you're affecting the endocardium, the innermost layer of the heart. So this infective endocarditis will come across due to one, sharing of syringes or needles, towels, and the person may be affected, alcohol, taking of alcohol. So such things will predispose you to infective endocarditis. And I won't ask you about the clinical features. Okay, so examples of these valvular heart diseases, I want you to know the examples. One, mitral stenosis. Two, mitral regurgitation. Three, aortic stenosis. Four, aortic regurgitation. So those are the most important valvular issues. Mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. Just for, if I give you an exam setting and then I tell you to list examples of valvular heart diseases, I expect you to give me those four. Yes. And I won't ask you about, no, given the level that you are in, I won't expect you to tell me the nitty-gritties regarding them. At least be able to know like the mitral valve can be able to narrow, that's mitral stenosis. The mitral valve can be able to like allow backflow of blood, so mitral regurgitation. The aortic valve can be able to narrow, so that is aortic stenosis. Aortic valve can be able to allow blood to flow back, so that's aortic regurgitation. Okay, so now we can go to cardiac infections. And for the cardiac infection, so by the word itself, so cardiac means heart, infections means being affected. So I gave by what I've talked about, infections to the heart walls, so it's related to heart dysfunction. And examples of types of these infections is that, remember the layers of the heart. We had endocardium, myocardium, and epicardium, which is pericardium. So infection of the heart is pericardium. So inflammation of pericardium due to infections. Myocardium is inflammation of the myocardium. Endocardium means inflammation of the endocardium and the valve. So from the layers of the heart, then you add carditis. So myocarditis, myocardium, pericarditis, pericardium, endocarditis, endocardium. And then you know which layer is it. So if I ask you now to give me the definition of pericardium, I'll be expecting you to tell me it's inflammation of the heart walls. Yes. And then now if you affect all the three layers, you'll have pancreatitis. All the three layers having. So what I will do at this point, given that I want to record this session and ideally I have this Zoom account is not paid, I'm going to end the session there and then I'm sending you a link immediately so that you join and then we continue from the session. Given that I want even your colleagues to benefit from this, I will end the session there and then we join in the next 1 minute. We continue from here. I'm actually almost like 3/4 done of the session. So give up. Yes, we can continue from there. So we had talked about this pericarditis, myocarditis, endocarditis, and pancreatitis. So for the etiology now, from there we can appreciate that we have the etiology means the causative agent at this point. So these causative agents with cardiac malformation can be viruses, so having the viral being the most common. Then the other one is bacterial. Bacterial means a good example is now the infective endocarditis. So for this infective endocarditis, we'll talk about staphylococcus and streptococcus, some of the bacteria that can really cause that. Then tuberculosis, which is actually like can lead to this cardiac infection that you got. Just tuberculosis is TB. Yes, for the pathophysiology, ideally because you have these infections leading to inflammation. So inflammation leading to impaired cardiac function. So you inflame the heart muscles can be able to contract well, leading to structural damage. So once you lead to structural damage, some vegetations may grow. Vegetations means like the stuff, for example, these infections, they can grow in the heart. Once they grow in the heart, they become vegetations and these vegetations can become dislodged, like inaweza ng'oka penye ilikuwa imekaa kwa heart, then inakuwa transported into their lungs, into the blood vessels, the liver and such. And that's the reason why you hear people talking about pulmonary embolism if you had such a thing. So that's how it works. And that's the reason why, guys, these things is actually real. So avoid these things. Avoid alcohol, avoid drugs, avoid eating a lot of sugary foods. Um, avoid junk foods and such to keep you healthy in that regard. So I think we can start. Given the fact that I had already alluded to this, so pericarditis and myocarditis. So pericarditis is now inflammation of the pericardium and causes those ones. So once again, I won't belabor on all that. But just wanted to show you this. So this is a pericardium in a normal heart. This is a normal heart here. In a normal heart, you can appreciate these are the heart muscles. Here, the heart itself. So that for the pericardium, if it's healthy, it will look like this. But if it's inflamed, this is what you will appreciate here. Of course, now you'll have now pericardial effusions leading to cardiac tamponade. In myocarditis, by the name itself, myocarditis, inflammation of the muscles, and those are the causes. They are viral causes such as Coxsackie viruses and autoimmune diseases. So it will present with those features there, clinical features, but it can progress to dilated cardiomyopathy. We talk about cardiomyopathy in a few minutes. So remember these are myocardium. These are myocardium now. If it is inflamed, you'll have myocarditis. And then if now, remember we have the endocardium here. If it's inflamed, you'll have endocarditis. They will come in the cardiovascular disease. So infective endocarditis now is what you're talking about. So this is an infection of the heart valves and endocardium, as we talked earlier. Common organisms of this infective endocarditis, we have Staphylococcus aureus and Streptococcus viridans. That's a good example of infective endocarditis, or of organisms that cause infective endocarditis. So Staphylococcus aureus and Streptococcus viridans, a good example of infectious causes of infective endocarditis. The risk factors of this infective endocarditis is that we have one, prosthetic valve. So people who have their heart being fixed because they have valvular dysfunction and then now they are put prosthetic valves, they have risks, they are predisposed to having infective endocarditis. Once again, intraventricular use of drug. So using of syringes and putting um, those drugs using the IVs will predispose yourself to having infective endocarditis, then pre-existing valve disease. And now this is what now it can lead to you. So if you have infective endocarditis due to prosthetic valves, infective drug use, pre-existing valve disease, one is that you'll have cardiac failure, as you can see here. So you can have your valve being perforated, having vegetations there, and the pacemaker having vegetations. So extracardiac malformations now will be, these are the fingers, is that they will turn black because of the peripheral infarcts there. You have an organ in the body known as the spleen. So because of those vegetations going to the spleen, we have splenic infarcts. Because you have those vegetations going to the lungs, you'll have septic pulmonary emboli. On the eyes, because you have those vegetations going to the eyes, you'll have rother spots. Because you have those vegetations going to the brain, you'll have stroke coming in. And that's it. So that's how now those presentations comes in, and extra cardiac malformation. These are the questions that I can ask you. I can tell you to list for me extra cardiac manifestation of infective endocarditis, and I'll be expecting you to tell me now of peripheral infarcts in the fingers and the toes, splenic infarcts, renal infarcts in the kidney, renal infarcts, which is not in this image, the rod spots in the eyes, and the stroke, and even infections, pyogenic brain abscesses in the brain. And the complications I've given you there. So, and now we go to rheumatic heart disease. So, I presume you know what is rheumatic fever. And now I'll also presume you at least know about cardiac infections. So, rheumatic heart disease now, rheumatic fever is now that fever that you get once you have infections due to um, stress, streptococcal pharyngitis. So that is what most common is known as sore throat. Ukiwa mtu akisema sore throat, ni kitu kayo kuna common cold, jua kuna streptococcus infection. Yes, so not everyone has common cold or sore throat has rheumatic fever. Kindly take note of that. Why? Rheumatic fever comes across when now you have the antibodies that were affecting this common cold now affecting the body now. Yes. So definition of rheumatic heart disease, autoimmune. Autoimmune means a disease that una produce antibodies. Antibodies need protective soldiers of the body. So these protective soldiers of the body, but they affect the pathogen, which is now the virus or the bacteria or something like that. They affect the body. So that's the reason it's autoimmune. Like I have my own antibodies now affecting my own tissues, and that is dangerous because you'll be expecting these antibodies to fight other things, but now they're affecting their own tissues. So, by definition, now this that is autoimmune complication of untreated group A streptococcal pharyngitis, commonly known as sore throat or something like that. Yeah. So the pathogenesis at this point is that you have molecular mimicry. This molecular mimicry is the now autoimmune aspect leading to antibodies attacking cardiac tissues, which affect now all the heart muscles. Then you have valvular involvement can be there, and then you have the mitral valve, which I told you is the most important one to be affected. And the features of this rheumatic fever is that fever is high body temperature, so without itself rheumatic fever, so fever will be there. The other one is that if these autoantibodies can affect the joints, so the person will have migratory polyarthritis. The person can have now the heart being affected, which is carditis, pancarditis, which you'll see in a few minutes. And the diagnostic criteria is the Jones criteria. This one I last in an exam setting, it's a common thing. What is the diagnostic criteria of rheumatic heart disease or rheumatic fever? And then I'll be expecting you to give me the Jones criteria, which has major, minor criterias, and also you can have evidence of streptococcal infections here. So we've seen this rheumatic fever is coming across due to streptococcal pharyngitis. So do you have a history of a sore throat? Okay, so how will it now? What will come across in this rheumatic heart disease? So remember, we talked about it affecting the heart muscles, also affecting the endocardium, the heart valves in that regard. So these are aortic valve, these are tricuspid valve, these are mitral valve. So what will happen is that in early stages, they will undergo regurgitation, like they can be able to allow backflow of blood. But now, in late manifestation of this rheumatic heart disease, that the heart muscles, due to fibrosis deposition of more fibrous tissue, leading to you having the stenosis. So the heart valves will narrow. So once the heart valves will narrow, that means we'll have the hypertrophy of cardiac muscles, which is cardiohypertrophy, that regard, or the cardiomegaly. Then from the cardiomegaly, you'll have heart failure. Yes. Then from the heart failure now will lead to due to vegetations to bring out filament tissues start meeting from one point. So that's now the pathology. So advanced and in commissional fusion in small appearance, the mitral valve, hemodynamics effects as your bodies. But just know the hemodynamic effect that you have the mitral stenosis, then left atrial enlargement to the left atrial enlargement, then pulmonary hypertension. So what is now the cardiomyopathies that we're talking about? So cardio means heart, and then myopathies means now unexplained or the diseases that are affecting the structural aspect of the heart. So definition of these cardiomyopathies, diseases of the myocardium. So myo means heart. So cardiomyo. So diseases of the muscles of the heart cause structural dysfunction of the myocardium. So classification into three. So these are normal hearts. So dilated means it's meant because they become larger. So dilated cardiomyopathies. So that's here. The difference between these and these is that this one is larger than this. But the reason it's dilated cardiomyopathy. So you have an issue with the pumping of blood because it's dilated. Veins are very big. Then hypertrophy means you have heart muscles hypertrophy more. So that's it. Hypertrophy means like enlarging in size. So hypertrophic cardiomyopathy, cardiomyopathy of increasing of this because hypertrophic cardiomyopathy means increasing in number of cells of the heart muscles. Then the one is restrictive. So restrictive means the heart muscles become stiff. Yes, become stiff. So age are maybe the predisposing factors or maybe can cause this cardiomyopathy. That one genetic predisposition, especially HCM is hypertrophic cardiomyopathy. Infections such as myocarditis. So remember now see the way infective endocarditis can be related to these cardiomyopathies. Toxins such as alcohol. Systemic diseases such as amyloidosis. Amyloidosis is the disease that affects the heart, the lungs, and the skin tissues. Yes, because of the deposit of amyloid. So in exams, I think I can tell you to discuss about cardiomyopathy. So I'll be expecting you to give me the definition of what we talked about, their classification into three: dilated, hypertrophic, and restrictive cardiomyopathies. And then I can tell you to give me the etiology, as you've said. So one description of the same, a more description of the same is that we'll have dilated cardiomyopathy is enlarged. By the way, it's dilated means enlarged chambers of the heart, especially the ventricles. So what happens is that due to the increase in the dilatation, there is decreased contractility of the walls of the heart muscles, leading to heart failure. Hypertrophic thickened heart muscles, especially now the septum. This leads to can lead to cardiac death. And then the other is restrictive cardiomyopathy, means stiff ventricles. Stiff ventricles lead to impaired diastole or impaired filling into the ventricles. Yeah, all these what they will lead to heart failure, lead to arrhythmias means inconsistencies in terms of the conduction of the heart. And then the other is thromboembolism. So the thromboembolism that talked about leading to the various conditions, stroke, peripheral infarcts. Yeah, so almost there, almost done. So arteries, arterial disorders. So, or arterial diseases. So by the definition, as you can see there, these are disorders affecting structure and function of arteries. Structure and function of arteries. I'll just go with the common ones at this point. One, atherosclerosis. So atherosclerosis means deposition of a plaque. Also, the thing is fat. It's deposition of lipids into the arteries leading to atherosclerosis. The other one is arteriosclerosis. Arteriosclerosis, this is now stiffening of folds of the arteries. And the other one is aneurysms. Aneurysms means bulging of the arteries. And sometimes of this condition is one hypertension. So if a person who has hypertension has actually risk of having aneurysms or atherosclerosis or atherosclerosis. But most of the time, in atherosclerosis, the most causative agent is hyperlipidemia. Hyperlipidemia means excessive lipids in circulations or fat in circulation. The eyes, of course, diabetes mellitus, a person who has diabetes, high blood circulation, or smoking, and even alcohol can have diseases, arteries, diseases of the arteries. Clinical significances, you can have reduced blood flow, of course. As you can see, even our normal artery, the blood is coming in, but not because of atherosclerosis. The person has fat, which is deposited on the tissue, leading to narrowing them, even of this artery. Of course, now leading to reduced blood fluid, ischemia, death of tissues, and risk of thrombosis and embolism if this sleeve is displaced from where it is, leading to thromboembolism. Then now we start to narrow down specifically. This one I won't ask you the major thing, but atherosclerosis, know the definition of this disease. Atherosclerosis means a disease where lipid-rich plaque is formed in the arterial walls. So, for example, and remember, this is deposited over time, not like you eat food and then you have that disease at the same time. So it has to be over a prolonged time. So that's the reason it's actually encouraged not to eat some kind of unsaturated fats. Yes. So you have fat streak, which is continuously being deposited, then becomes incorporated in the fibrous cup, from the fibrous cup, narrow down the lumen. So now you narrow down the lumen, this lumen once you have hypertension. From there, now you have this big beam, this is giving you metabolism. It happens in the heart, you have myocardial infarction. Yes, so atherosclerosis by that regard, just to make you understand now, I'm repeating, atherosclerosis is a disease that affects the arteries or the atheromas, the arteries specifically, where there is lipid-rich deposition. Yes. Then from there, for the pathogenesis, that not majorly about it, where you'll be expected for you to know about the endothelial injury, LDL accumulation, plaque formation. Yes, but the commonest sites of this atherosclerosis is coronary arteries, carotid arteries, and the aorta. Okay. So I can see there is someone who has raised his hand. Can we be able to answer that because I'm almost done? Can I tackle the question at the end if that's okay? Yes, I hope that's okay. So that at least I finish up and then you can be able to ask me the questions at the end. I will come to that in a few minutes. I'm just three or four, five slides remaining. The other one is arteriosclerosis and aneurysms. So arteriosclerosis, as I had mentioned earlier, so arterio means artery. Sclerosis means like there is stiffening and thickening. So thickening and stiffening arterial walls. So from the thing it's a arteriosclerosis. So arterio is the artery sclerosis and thickening and stiffening. So thickening and stiffening arterial walls. And you can have two types, hairline and hyperplastic. So just know about those two definitions of arteriosclerosis, thickening and stiffening. And then in exam setting, I can tell you to differentiate between arteriosclerosis and aneurysm. So what are aneurysms? Aneurysms is actually bulging or localized dilatation of an artery. For example, you can see this image here. So this is the bulging, the dilatation of the aorta. Remember the aorta going downwards here. So the kidney, so this is the aorta. So in the thoracic aorta, you can see it's bulging there. The normal one looks like this. If it bulges, you have aneurysm. So thoracic aneurysms, aneurysm. So aneurysms is like the bulging, the localized dilatation of an artery. And you can have two types, true aneurysms versus false aneurysms. In arteriosclerosis, we have hairline and hyperplastic. In aneurysms, we have true and false, and true and false aneurysm. In arteriosclerosis, you have hairline and hyperplastic arteriosclerosis. So causes of these two, one, hypertension, the other one is atherosclerosis. So atherosclerosis is a cause of both aneurysms and to some extent arteriosclerosis. Complication of this now aneurysms, one, they can rupture because considered dilated. Once they rupture, um, you can have now stroke if it's a brain or maybe infarct in other tissues. Thrombosis can clot because it's dilated, so there is cooling of blood, thrombosis there. Then to hypertension. So hypertension is now this one is actually, I presume this one you know. Hypertension is now persistent elevation of blood pressure over time. Persistent elevation of blood pressure over time. Types of hypertension. So you know the normal blood pressure of a person should be 120 over 80. Of course, it's a range, but just know it's around 120 over 80. In some books, you'll see it being indicated as 100 to 140 over 80 to 100. So that's or 60 to 100, sorry, 60 to 90. So it should be 100 to 140 over 60 to 90. That's the normal the normal range, but the most of the time is 120 over 80. That's the normal range. So types of hypertension, you can have primary and secondary. So primary is the one that is now it's essential, also known as essential hypertension. This one is its cause is not known. But in secondary means this hypertension is coming with other diseases. So for example, you saw atherosclerosis. Atherosclerosis is the narrowing of the arteries or the blood vessels, leading to once you narrow down the blood vessels means you are increasing the hypertension, like blood is increased blood pressure. The cardiac output is like it's being forced. So that's a secondary cause. So most of the time, primary hypertension is cause is not known, but secondary is caused because of other diseases which are not necessarily the arteries themselves. So effects on the arteries is that you'll have endothelial injury. Endothelial means the innermost part of the arteries being affected, endothelial damage, and then canal ciliates, atherosclerosis. And then also you can damage this hypertension you usually have. You can damage a person with hypertension needs to be checked because or to be under medical care because you can damage the heart. You can have left ventricular hypertrophy. When you have left ventricular hypertrophy, you can have heart failure. You can have stroke. You can have kidney nephropathies. You can have, once again, atherosclerosis. You can have splenic infarcts, liver cirrhosis, like all those conditions, they can come in. Yes. And then now to the last bit, these are the venous disorders. For the venous disorders, these are now the conditions that coming across or diseases that are coming across due to the impaired venous return or valve function. By definition, venous disorder is conditions affecting venous return and valve function. Because it's a normal filter, normal filter, one being open, one being closed. So closing one is closing one. So in a valve or a dilated valve, we can see it as an open valve. It's actually one, it's really one. So the valve can't close it, so they keep one that in that. So common disorders or common examples of these venous disorders. One, you have a vein thrombosis. Like because of this dilatation now, blood comes in and clots, giving you deep vein thrombosis, DVT. You have venous DVT. The other one is varicose veins, which you can see here. So varicose veins is veins that you can see here. The other one is hemorrhoids. Hemorrhoids, you see examples, but now, so these are the few examples. I can tell you to define and give examples of common vein malformations. Predisposing factors, immobility, or actually resting. So to avoid kulala sana, so people who sleep a lot or maybe they're in one place a lot. Like or they are just stagnant, maybe they are driving or they are resting for prolonged hours, maybe 8, 9, 10 hours, 20 hours in one place. That's prolonged activity can develop in disorders. Is pregnancy. Of course, pregnancy you'll be mobilized kidogo. The obesity, then hypercoagulable state means if you are taking drugs that can prevent, that can encourage or can enable the blood to clot, that's hypercoagulable states. And for the pathophysiology, you'll come to the visual triad, but understand that this is varicose veins here. So we start with one, deep venous thrombosis. So what is deep venous thrombosis? From the word itself, deep. So deep veins are affected. Then thrombosis is formation of a clot. So by definition is formation of a clot in deep veins, usually on the lower limb or sometimes even in the upper limb. So from the word itself, we get the definition. So deep venous thrombosis, formation of clot in deep veins, usually in the lower limb. risk factors for you having this deep venous thrombosis, or maybe actually you can tell a person with deep venous thrombosis. Why? In the ukimuuliza maswali, the person will say that I was standing, or maybe I was resting, nilikuwa nalala for like 20 30 or 20 hours in a day for like a month. Like that person was immobilized for that all that time. The other one is you can have hypercoagulable states. Like you've been taking, some people will talk about, I've been taking warfarin. Warfarin is a drug. I've been taking warfarin. Then the other one is endothelial injury. That one happens in the body. Okay. Then features, of course, due to this formation of plates, utakuwa na leg swelling. Then of course you'll have pain, and then the leg will be feeling warm. And the tenderness is like nikifinya unasikia uchungu sana. And that's how now it will be looking. So you can see this is the leg that you're talking about. This person has different as losses. So because this leg is bigger than this one, so it's like has really needs. Of course, you can feel the constant uchungu, pain, then this leg is warm, and the other one, and then the tenderness. That's that. Then complication now is that these clots that are formed in these deep veins, the lower limbs, they can go to the heart, from the heart to the lungs. Once they go to the lungs, they lead to pulmonary embolism. Then varicose veins. So varicose veins is by definition itself dilated or just superficial veins. And you can see them here. So it's the dilated veins, superficial veins. So the cause of this due to the leaky valves. So valve incompetence. It one, there's a heavy because of accumulation of blood in these spaces, and then visible veins that you can see them there. Then the other one is hemorrhoids. So for hemorrhoids, is actually dilated veins in the rectal plexus. So these are the veins in the rectum. So as you can see, this image, this is the rectum here, this is the inner. So you have veins in there. So if these veins dilate, you have hemorrhoids. So you can have two types of hemorrhoids. You can have internal hemorrhoids, as you can see here, and external hemorrhoids that can appear now on the inner region. So these hemorrhoids, you have internal versus external hemorrhoids. Symptoms, bleeding, pain, and the complications that you can have ulcers and thrombosis. So a good example is now an external one that you can be able to have a see. It's an external hemorrhoid. Example one, so you can see there, these are the external hemorrhoids. This now I will give you an assignment. I will send you this chart, which I will expect you to go through, of the differences between arterial and venous disorders. Yeah, so there are simple things what we talked about. So for example, now, arterial disease, what it happen is that you have reduced blood supply. In venous disease, venous return stasis. Common causes are the arterial diseases, and venous disorders as well, incompetence and thrombosis. Blood flow is arterial disease from heart tissues, venous because it's from the system, so it's from tissues to the heart. And typically, these are talked about the symptoms, skin changes, complications, we talked about it. So for the investigations, allow me to skip this because this is not the scope of what you're supposed to cover. And even the treatment and management. So this is for higher level. But just know you can have basic tests. You check on the blood pressure, pulse, blood tests such as lipid profile. You could take an ECG, is electrocardiography. You can do imaging with chest X-ray, echocardiography, can do advanced imaging such as CT, which is coronary results, angiography, can do an MRI of the heart, can do receive investigations such as cardiac catheterization, and tests such as Doppler for pneumonia DVT, and exercise stress test. Yeah. Treatment, of course, the person, okay, lifestyle modification, as you can see here. So diet, eating low salt foods, low fats, you exercise well, you avoid smoking, you avoid alcohol, then now you take drugs according to the pills that you have. So pharmacological therapy, kama uko na hypertension, you take antihypertensive. Kama uko na any issue with coagulation, you take antiplatelets. If you have a lot of fat, you take lipid lowering agents. If you have kidney issues, you take diuretics. Yeah, so that's the management that you consider. And eating preventive strategies. So you do regular screening and risk factor control. So avoid hypertension, avoid diabetes, and avoid obesity. So with that, I'm coming to the end of my presentation. Remember, God always hard work and patience, and so hard work kujituma. So because it is bad here, I tell you, still it's hard work and patience that enables you to have such a thing on this other end. So kujituma in that regard and telling God to bless the work of your hands. So that's it from me. Yes. So any questions now?